Thank you. Thank you, Vicki, for an all too kind introduction. I feel like even that is a hard act to follow, but really appreciate everyone coming out this evening to join us for this public lecture. I never expected such a diverse and fantastic turnout, so really appreciate everyone taking the time on a weekday evening to come listen to this talk. I'm going to be sharing a little bit about the importance of sport and physical activity in terms of public health outcomes for people with disabilities, how what we do in Paralympic sport can sometimes potentially influence that, a little bit about my own story and so on, and I hope to end in plenty of time so that we can have a lively discussion. I think talks like this should be provocative in some way, so hopefully we'll bring up some provocative things that we can then debate at the end of the talk. I'm currently an assistant professor in physical medicine and rehabilitation at Harvard. I direct a very small, nothing akin to the size of the Peter Harrison Center, but a small initiative called the Kelly Adaptive Sports Research Institute. I chair the IPC Medical Committee and also sit on the Medical and Scientific Expert Group for the IOC. And I, like many of you, I'm a bit old to this world, but I'm trying to get more involved in social media, so I wanted to share my Twitter handle there if anyone wants to post for this evening. I'm just figuring out how to use it myself. All right. So I wanted to start with this photo. Many of you may know this athlete or maybe not. This is a racer named Marcel Hug from Switzerland, a very successful athlete. In the Paralympic world, people have dubbed him the Silver Bullet. He's won multiple medals in the Paralympic Games, multiple international marathons. And I think that when you see a picture of Marcel, clearly, you think of athleticism, you think of power, skill, and achievement, right? And as the Paralympic movement grows, and with the work we're doing with the International Paralympic Committee, I think that more and more audiences around the world are able to see the achievements of athletes like Marcel. But one that I wanted to talk about this evening is how that can potentially translate to thinking about how we transform our societal expectations regarding physical activity for people with disabilities in general. We all know the logo on the left, which is sort of the standard international symbol for disability. And there's been a movement to transition it to the logo on the right, which is similar in character, but portrays a person potentially with more movement, with, I think even seeing it, you think more autonomy, more independence perhaps. And there's a fledgling group in Boston who's they're actually doing it in kind of undercover style. They're trying to change all the logos and parking lots and on signs to the second logo. They're putting up decals, probably not being allowed to, but doing it anyway, because it's so important that we transition how we think about people with disabilities in general towards what is possible with regards to movement, physical activity, and sport. And so with it, I think that we have the potential to create a health transformation, particularly by redefining our expectations. And I just wanted to briefly note that when we think about elite sport, Paralympic sport, certainly we're interested in enabling athletes to win medals, to show their athletic prowess and to achieve. But if you look at the strategic plan for the IPC, that outer ring refers to aspiration, and the aspiration of the movement is to make for a more inclusive society for people with an impairment through Parasport. So yes, it's all about putting on a fantastic Paralympic Games and making sure that our audiences around the world can see the spectacular performances of our athletes, but at the end of the day, it's about more than that. And it's about transitioning our mindset about what's possible. And I briefly wanted to touch upon my own journey. So, as Vicki kindly pointed out, I was a wheelchair racer and competed in 3 Paralympic Games, but I certainly didn't start out with that aspiration. I actually grew up in a very rural part of the U.S., in Iowa, which is a state, state right in the middle of the country. In the U.S., we joke it's one of the flyover states, because you're either on the East Coast or the West Coast, and then you fly over the rest of it. And I grew up in a farming community. And I acquired a spinal cord injury quite young, at about 16 months of age. So when I was growing up, I was really the only kid with a disability in my community. And I had no idea that there was a world of adaptive sport or parasport out there. And because of that, as I was growing up, I started to shift to activities that were very sedentary. And I was very active in school, but I was in band and student council, and I never ever thought of myself as an athlete. And I had a lucky moment, really, and it was luck at that time, that I met a coach who had learned about the sport of wheelchair racing. And being from a small community, he knew me, and he found me in school one day, and he said, hey, I just learned about this wheelchair racing, and I don't know anything about it, but if you're willing to try, I'm willing to learn and to coach you. And he was just a wonderful individual, and took a leap of faith in a way, I think, to offer to coach an athlete in a sport that he wasn't familiar with, but that he knew could be impactful. So I went out for the track team, and I didn't have a racing chair. I was pushing in my everyday chair. And we did the regional circuit of track meets. And at each track meet, they would put a 100-meter wheelchair event on the program so that I could have an event to compete in. I was usually the only athlete competing against myself. It was actually very embarrassing for a freshman in high school, but I stuck with it. And at the end of that first season, I actually was able to go to a larger track meet that was in the capital of Iowa, which is Des Moines. And I met several other teenage girls who were also engaged in the sport of wheelchair racing. And I can honestly say that that day was absolutely transformative to my life, because before I met them and before I saw peers who had a similar disability to mine that were active, that were competing in sports, I would have never had the self-concept of being an athlete. But I met those young ladies and learned that there was a wheelchair racing team that practiced in a city about 4 hours away. And I was immediately intrigued, mostly because I wanted to be friends with them, because I didn't have any other friends who were also wheelchair users. And I started to go to practice, and then learned more about the sport, and then acquired a racing chair, and so on and so forth. And many years later, had the opportunity to compete for Team USA in the Paralympic Games. But it was really all about in my life, one lucky moment where a track coach saw that there was potential there, and he, wanted me to have the similar opportunities to be involved in sport as my peers. And in many ways, I think that the talk this evening, and hopefully, what I can impart, is that all of us could have the role of being that person in someone else's life, and that we do need to continue to create more opportunities where it's not a lucky break, but rather something that's more ubiquitously available, and more of an expectation that we get young people involved in sport, similar to their able-bodied peers. This is a young girl who lives in the Boston area. Her name is Maddie. She's 8, and she has a pink racing chair, and she's out there in the wheelchair racing circuit, and I have no doubt that she'll be on the team in potentially LA 2028, and she's there holding the Boston Marathon trophy. So it's all about passing it forward to the next generation. A brief outline for the evening about a little bit more about the meat of the talk. We'll talk a little bit about disability and health disparities. I want to talk a little bit about what we know about sport and physical activity as an intervention. What is its potential impact? What are the drawbacks? And then a little bit about whether participation in sport and physical activity, is it an opportunity, or is it a privilege, or is it actually a human rights-based issue? Talk a little bit about how we can promote access and opportunity through concepts of universal design, and then ultimately maximizing our impact as professionals who work in the space. So, I think this is a familiar statistic to everyone in the room, but I just wanted to briefly remind us that when we think about the potential impact of getting people moving, or sport and physical activity for people with disabilities, that this is not just a nice thing to do for a small subset of people, but rather something that impacts a huge amount of our population. 15 to 20%, and greater than 1 billion people worldwide. This was information from the WHO World Report on Disability, and we continue to see those numbers supported in other population health initiatives. So we do a lot in the general population to promote physical activity. Here are some examples. The American College of Sport Medicine, which is a huge sport and exercise medicine society, has a huge initiative called Exercise is Medicine. The UN every year has an International Day of Sport for Development and Peace. Healthy People 2020 is a U.S. government-based initiative. There's similar initiatives in various countries around the world. The WHO in the past has put on what's called the World Health Day, Move for Health. So it's very clear that we're trying to support opportunities for physical activity across our population. But I have to ask the question of whether or not these are designed correctly to meet the needs or to change behaviors in people with impairment or disability. And I think that, unfortunately, most of them don't pay enough attention to this population or create programs that are unique to change behaviors in this population. So we need to do more. Just a few slides talking about US data, and I think this is quite similar in many developed countries around the world. There's a large population study in the US called the National Health Interview Survey, where they interview thousands and thousands of people across the country and ask them about basic health behaviors. And this is also the population health survey that's thought to gather the best data about disability. When they make these calls, they ask people about whether they have, in layman's terms, movement difficulty, emotional difficulty, seeing or hearing difficulty, or cognitive difficulty. And if you look at people who self-describe as having a disability in any of these categories, you notice that certainly they're more likely to be obese or overweight, and with that, also more likely to be inactive. So here we see, obviously, an unfortunate mismatch of people experiencing chronic disease, but also moving less and not being as engaged in leisure time physical activity. The survey also looked a little bit about other behaviors, and so information dating back to the around 2009 to 2012 timeframe noted that 1 in 2, or nearly half of adults with disabilities, get no aerobic physical activity at all, and are 50% more likely to report one chronic disease than active adults with disabilities. So if you have a disability and you're able to engage in physical activity, then intuitively you're going to have typically less chronic disease. Also concerning was that less than half indicated that they received physical activity recommendations from a health professional. So I bring this up just to say that I think that we have to look far beyond just the people that we're working with, or people with disabilities in general, and also look at the influences around them. And I know in the US that we still have somewhat of a bias, even in the health professions, towards when we see someone with at least a visible disability, we're less likely intuitively to counsel that person about the importance of exercise. So there's a bit of a mismatch between even our own expectations as health professionals at times. So there's been some work looking at barriers to physical activity. Many of you may know Jim Rimmer, who's now at the Lakeshore Foundation and University of Alabama, Birmingham in the US. And he's done a number of studies over the years, many of them quite interesting. This is a very simple survey that talked to adults who had had a stroke and who had hemiplegia, and asked them about their barriers to exercise. And what you see here is that factors related to the environment, particularly those who reported lower socioeconomic status, were tantamount in terms of what people described as what held them back from engaging in exercise. So things like the cost of the program, not knowing where to go, difficulty with transportation is a big one and continues to be a big barrier, and then not knowing what to do once they get to that facility. And I think that's important to note, because all these things are things that are modifiable. It's much less having to do with people's inherent motivation, but more so the environmental barriers that they face when trying to become engaged. And one of the challenges, I think, is that when we think about how to design an intervention or a physical activity program, when we think about disability, it's a very heterogeneous population. When we think about the minority group, if we compare people with disabilities to women or people of diverse racial and ethnic backgrounds, we're very heterogeneous as it relates to disability. And so what might be ideal for a middle-aged gentleman with a spinal cord injury who wants to play sports may not be ideal for someone who's elderly and accumulating the effects of aging, or someone with intellectual disability such as Down syndrome. And so I think that, honestly, the heterogeneity of our population is in itself a barrier, because when you look at people who are designing these large physical activity programs or interventions, I think they become quite intimidated about disability, not knowing quite how to tackle that heterogeneity and how to address it appropriately. When we think about access to the built environment, there's certainly objective evidence that our facilities and our places where people go to exercise are not always as welcoming as they could be, both in terms of physical access, but as well as attitudes. And that makes a big difference, because the environment itself, or the natural environment, is often also less friendly to people, particularly with mobility or sensory impairment. This was a simple survey looking at 35 fitness facilities across the US, and they looked at it from the standpoint of these 6 factors related to the built environment, the available equipment, the swimming facilities, if it was available, information that was provided, the policies and professional behavior of the people there. And what did they find? Well, they found that a lot of facilities, could check the box of having a ramp to the front door, but when you really got inside, few of them met all the specifications with regards to things like the locker rooms or power assist doors to navigate the environment. This is a biggie. Less than 10% had upper body options for upper body cardiovascular exercise. So, of course, important for many people with mobility-related disability. And less than 25% had adequate space between machines. And I think this is very telling. A lot of people will say, well, I can get to the gym, but once I get there, I don't have anything to do. Because it's all treadmills or spin classes. And the programming and the equipment available doesn't meet their needs. About half had pool lifts, something that's still not as ubiquitously present as it should be. Less than 25% had information, schedules, directions, location, this type of thing in accessible formats like Braille or large print, or accessible signage for people with sensory disabilities. And thankfully they looked a little bit about attitudes as well and about just sort of the treatment that you experience while you're there. And on the positive side, they noted that as a simple indicator of kind of disability and cultural competency, that at over 85% of the facilities, at least the staff would ask a person with disability what type of help they needed before making assumptions or before simply imposing themselves on that person. So that was a good thing. And again, just pointing out that if we don't think about more universality or more accessibility of our places where people go to exercise and fitness facilities, then we're really running up to a barrier because the things that most folks do to exercise, i.e. I'm going to go out my front door and go on a run or go on a quick bike, if you're a really savvy person and have the right equipment, that might be possible, but for a lot of people with disabilities, the natural environment is simply not as friendly as an immediate go-to or an easy way to get exercise. And again, I wanted to return briefly to the barrier of potentially our own attitudes. So this is a short piece that was published in JAMA in 2002 that really resonated with me, particularly this phrase about the vicious cycle of inactivity for people with disabilities, wherein oftentimes one becomes inactive. Because of that, you start to accumulate chronic disease, and with it disability, and then that in and of itself leads to less activity. So it becomes this cycle, and we've all seen it happen to people that we know in our lives, where disability and chronic disease are very much interrelated, and chronic disease is in and of itself a cause of disability. So once people get into that vicious cycle, it can be quite difficult to break out of it. And again, it was noted in this work that people with more severe upper or lower extremity mobility impairment were not as likely to receive exercise counseling. So I think people reach this precipice where there's so much going on, and the burden of chronic disease is high enough that exercise just becomes less of a priority during those office visits, for example, or when working with health professionals. And what we have to do is create opportunities for people to break out of this cycle and change the expectation. So I wanted to now segue just a bit into thinking about, we've talked now about the fact that we consider physical activity and exercise to be a high priority. And yes, there are community barriers, but if we can get around those barriers, then I think it's important to ask, well, what should that intervention look like, or what should we be advising people to do? And there's a general population that is well known, initially supported by the WHO and now by many groups around the world, that able-bodied adults should be engaging in 150 minutes per week of at least moderate intensity physical activity, as well as strength training, balance training, and so on. But more recently, people have begun to look at, well, does that apply for people with various types of disabilities? So I'm going to look at 3 examples here, stroke, traumatic brain injury, and spinal cord injury, to think a little bit about, well, what might be the impact of physical activity if we can get people to engage at an adequate level. So first, talking about spinal cord injury, there's plenty of evidence, and increasingly so, more coming out with regard to the fact that exercise is helpful in the prevention of chronic disease as well as improved performance. Some studies are listed here, from the standpoint of cardiometabolic health, things like improvement in lipid profiles and reduction in inflammatory markers, improvements in muscle strength and lean body mass, improvements even with VO2 max, particularly with FES training, where people are engaging the lower extremity or limbs with paralysis in electrical stimulation and engaging those muscle groups in exercise. And wanted to point to the good work of international group, also supported by our colleague Sarah Lufbrow. Jan was heavily involved in this, as well as Dr. Tolfree. And there are new guidelines for exercise and spinal cord injury that came out just late last year, and they're noted here. So from the standpoint of looking at cardiorespiratory fitness and muscle strength, the recommendation is, at a minimum, 20 minutes 2 times a week, moderate to vigorous intensity, as well as strength training. And then from the standpoint of also looking at changes in cardiometabolic health, the threshold is a bit higher. Ideally 30 minutes 3 times a week, moderate to vigorous intensity physical activity. So this is one of the only examples of looking at a population of people with disabilities, looking at the evidence and saying, how does that 150 minutes a week that we report for the general population, does that apply to people with disabilities or not? And actually using the evidence to support guidelines that are specific to people with SCI. So this is tremendous work that's been done, and many thanks to those in the room who are involved in the development of this work. When we think about cerebrovascular accident or stroke, there's increasing work looking at both things like cardiovascular health, but even now people looking more at things like neurorecovery. So there's strong evidence, for example, that exercise can be helpful in improving cardiovascular and metabolic fitness, extremely important, particularly given that many people who have experienced stroke, or most people who have experienced stroke, already have cardiovascular disease to some extent. So both preventing further decline, but also preventing secondary stroke or repeat episodes is very important in this population. There's also evidence that exercise can improve ambulatory capacity, i.e. function in day-to-day life. And there's more and more people that are looking at some of the cognitive symptoms that occur after stroke and noting that physical activity or an exercise intervention can be quite helpful in areas such as improving depressive symptoms. Depression is very common after stroke, so if we can move the needle there, that would be a big breakthrough. Looking at things like memory and executive function, as well as fatigue, which is also a huge issue after someone's experienced a stroke. So it's more than just cardiovascular fitness, but also cognitive performance when one's experienced a central neurologic injury of this type. The American Heart Association has published exercise recommendations for people with stroke, developed, I believe, via a different process than what was done for SCI, but at least helpful to be aware of. And these are noted here, having to do with aerobic training, muscle strength, as well as neuromuscular control. And it's important to note that at least this is being brought up as a very important aspect of health after one experiences a stroke. And I think it's interesting, in this population, by definition, most people who have experienced a stroke are somewhat at increased risk for adverse events if they really push themselves in exercise as well. So the AHA also recommends that prior to engaging in moderate to vigorous physical activity, that in this population that we engage in medical history, physical exam, and if possible, graded exercise testing, just to make sure it's safe before you then really push people physiologically to their limit. I wanted to bring up the fact that I think that very, very frequently, stroke is a very common disability that's in our population. It's far more common than spinal cord injury, for example, or traumatic brain injury. But oftentimes when we think about folks who have experienced a stroke, it's often an older population, not always, but frequently. And frequently we think about things like medication, for example, anticoagulation, medications like cooling, or lipid-lowering agents. But we very rarely, in that plan after someone's had a stroke, include physical activity as a requirement for their progress and their health maintenance moving forward. So this is an area where if we can change expectations, it could have a huge impact on that large population. Wanted to touch a bit on traumatic brain injury because there's some exciting work going on in this area. So when we think about the changes that occur centrally with physical activity and exercise, there's a lot of folks thinking that it as an intervention can very much help with neurocognitive function after traumatic brain injury. Things like forming new synapses or neurogenesis, for example, or neuroplasticity. The brain has a lot of plasticity, and so after you've experienced something like a TBI, it's very interesting to see what can be done to improve gaining new function even after the injury. And there's some small prospective studies that are looking at people that have had more moderate to severe injuries and looking at the fact that exercise interventions may actually improve cognitive function. For example, after TBI, there's a lot of cognitive testing that's done to kind of track how people do over time, and they've noticed that when they engage people in a controlled intervention of exercise, that they actually do better on some of these tests. Additionally, I wanted to touch upon this large area of work related to concussion or mild TBI, and increasingly we're seeing that that it used to be that we strongly advised a fairly prolonged period of rest after concussion, and if you look at the more recent guidelines from the 2016 Berlin Consensus Group, that period of rest is now being shortened and shortened and shortened, and now it's recommended, I'll just jump ahead here, that there's a debrief period, initial period of 24 to 48 hours, but then after that it's actually okay to start to progress people and engage them in exercise that doesn't bring them to their clinical threshold of worsening concussive symptoms, but if it's a sub-threshold level of exercise, that's actually helpful and can stimulate recovery. So it used to be we'd hold them back, someone would have a concussion and we put them in a dark room and tell them that they couldn't watch TV or engage with their peers or certainly couldn't exercise. And now we're realizing that the exercise component probably actually has a role as long as it's not to the level that's worsening symptoms at that time. And if so, then you have to back off again and give it a longer period of rest. So in this paradigm, when we talk about concussion is a very hot topic right now, and it's important to know that exercise can play a role in recovery even in this group. So just wanted to pause and take a moment. So clearly we've talked about the fact that we looked at population studies noting that people with disabilities are, in general, more likely to be sedentary, more likely, unfortunately, to experience the effect of chronic disease. So as a general principle, the risk of not engaging in enough exercise is much greater than the risk of engaging in too much. But just wanted to briefly touch upon some of our work that looks at things like musculoskeletal injury in athletes with disabilities or people who are engaging in a higher level of sport and exercise, noting that there certainly is a threshold where if you do too much, then certainly there can also be health detriment. Some of the work that we've done in looking at Paralympic athletes at the Paralympic Games looks intuitively that the upper extremity is at particular risk. And when we engage people in physical activity exercise, and particularly in lead sport, we have to be aware of this and ensure that we're doing everything we can in terms of injury prevention to make sure that 10 years down the road, 20 years down the road, our athletes are still in great shape and are able to continue to engage in exercise recreationally even beyond their elite sport career. So this is a consideration, but certainly shouldn't be a deterrent to the fact that by far and away more people need to move more rather than less. All right. So now I wanted to talk a little bit about the fact that we know that people need to move more. We know that exercise is a really important intervention, but more than just being something that's good to do, more and more so now we're seeing participation in sport and exercise as a rights-based issue. Some examples of that. In 2006, the United Nations ratified the Convention on the Rights of People with Disabilities. This is a large human rights document developed over many years and with UN member nations weighing in on what should be included. And interestingly, Article 30.5 actually noted that participation in cultural life, recreation, leisure, and sport is a rights-based issue. So this was up there in the same document with things like a right to education and a right to health care, a right to fair housing. And I think this is really important because this was a document that was developed by UN member nations, but also with direct input of people with disabilities. And so clearly, when we ask folks and ask them, what is up there in terms of what you consider to be important for your rights, the ability to engage in leisure and sport and recreation is a very critical topic. The WHO is currently working on a new revised global action plan for physical activity. This has been in draft, and the period where people are able to weigh in on what they feel should be included in this document. And the preamble or the initiation of this work has noted that health is a universal right, and insufficient physical activity is one of the leading risk factors of death worldwide. I think now that's very supported by evidence, but this does include very specific mention of people with disabilities as being part of this discussion about health as a right, physical activity as a rights-based issue. I wanted to briefly touch upon athlete activism. So in the U.S., we've seen over the years that athletes themselves pushing for what they feel are their rights have really moved the needle in terms of participation at the community level. One example is a fairly well-known athlete, Tatiana McFadden, also a wheelchair racer. And when she was in high school in the state of Maryland, she was able to be a part of her track team for practices, but when they would go to competition, she wasn't able to score points for her team. And her and her family actually brought a suit against the American Public Schools Athletic Association and won. And because of this, there was an act that was passed that enabled full participation of students with disabilities in high school sports alongside their peers. This is for the state of Maryland, but you see that now as legal precedent for many different states across the country, where for many, many years at the high school level, students with disabilities have been excluded from competitive sport. So the voice of athletes is extremely important to moving this forward. At the collegiate level, in Boston, we have an athlete at Harvard, Nikki Maxwell, who's a Bologna amputee. He's quite talented, and he's actually been pushing to be fully included on the Harvard track and field team. There's a lot of work, a lot of advocacy going on with what we call the NCAA, which is our intercollegiate sporting body. And up to this day, and even now, they've still been very reticent to include opportunities for students with disabilities at the collegiate level. Most of what does go on is more like club teams and what we call intramural, more recreation level sports. But if you look at that highest tier of competition, for example, comparative sports like men's football or men's and women's basketball, there's still no opportunity for athletes with disabilities. And so athletes like Nikki are really pushing the envelope on that in a very public and loud way. And it's that type of voice that's going to help to create change, because athletes clearly have one of the most compelling voices in terms of what their rights should be for equal competition. There's some great international models. If we look at competitive sport, I wanted to point to the example of the International Tennis Federation, which has done a particularly good job at creating inclusion at the within their international federation. And at the elite competitive level, you see wheelchair tennis present and as a competitive category at all the elite Grand Slams. Just like you have a men's open winner at the U.S. Open, you also have a winner in the wheelchair division. Additionally, the ITF has done a lot of work with regards to their development fund and opening up opportunities for participation in tennis in areas around the world that are less developed, where the barriers from a socioeconomic standpoint are higher. So just bring this up as an example of the fact that it can be done. The ITF is a very well-resourced federation, so I'm sure that helps. But certainly a model for inclusion between able-bodied athletes and athletes with disabilities. So when we think about what we can do, so what's the road forward? I think about it this way, that we know that these barriers are certainly real, and because of these barriers, there's significant health disparities for our population. But how can we change expectations and also along the way change our own mindset around this? And I think it really comes down to two things. The first is seeing sports and physical activity through universal design, and I'm going to talk a bit about that. And then using our voice to advocate for expanding opportunities. So universal design is is simply put, design that works for everyone regardless of disability. So this is a really important area of work that's developed internationally, not just with regards to sport and physical activity, but across the board. So one example is this entrance to a public park in Canada, where you see that anyone can enter the park seamlessly together, whether you're using the stairs or you're using the ramp. So that's an example of universal design. You know, how frequently we see all the time where, yes, there's a ramp into the building, but it might be like around the back by the dumpster. There's a sign and 5 different signs that point to that ramp. So when you create integration like this or universal design, like in this example, you enable people to participate side by side on an equal basis without creating a mindset of us and them, or that we're doing something that's special and unique for people with disabilities, but we're not doing it for the mainstream. What we want to do is get beyond that and prove that as it relates to physical activity, the changes that we make to make it more inclusive help everyone, particularly given that everyone interfaces with disability at some point in their life. So some examples. As it relates to infrastructure, there are really great checklists that can be used at fitness facilities. This is just a screenshot of one example, talking about the space between cardio machines to ensure that people with mobility equipment can navigate. So, you know, there are standards of excellence and guidance for this that we can use in our Main Street facilities to make the environment more inclusive. And it's not just about the space, but as I mentioned earlier, it's also about programming. So one example is at the Lakeshore Foundation in Birmingham, where they have a fleet of these crank cycles, and they're able to have both spin class as well as crank class, and everybody can participate in either. So this is fantastic because a wheelchair user can come to the gym and decide if they want to do a cardio class, but do that cardio class with their peers. And a person without a disability can come to the gym and say, well, today I feel like doing the upper body spin class or the lower body spin class. So this is a great example of universal design. You know, it works for everyone, everybody gets to choose, and people can participate side by side. With this particular piece of equipment, you can also move the seat. You can leave the seat in place if you're someone with potentially like a balance impairment or someone with a lower extremity injury. You can move the seat out altogether if you want to pull up as a wheelchair user, or if you want to simply stand and engage your core while you're cranking with your upper body. So it really is a quite universal piece of equipment, and then one example of how we can make mainstream fitness facilities a bit more friendly to people with various types of mobility-related disability. When we think about sports specifically, you know, there are certainly ways in which, particularly at the development level in more community-based programs, we can think about making opportunities more universal. One example is the sport of sled hockey, where at the community level, most teams can be comprised of a mix of people with disabilities and a mix of people without disabilities. And that makes a lot of sense because by doing that, you have more teams, you have more ability to host tournaments with exciting matches, and you also make it such that friends can compete together, and it's not a separate team or a separate sport for people only with disabilities, but rather it's open for both people with disabilities and their able-bodied peers, friends, and family. And there's rules around it so that it makes sense. You know, every team has to be comprised of a certain number of people with disabilities, as well as a certain number of spots are also open for people who are able-bodied. But in designing the sport this way, it actually helps grassroots growth and enables talent development for young athletes, as well as inclusion, you know, greater awareness about the sport. And then when you get to the elite Paralympic level, then it really tapers down, and it's primarily for people with disabilities. So I think this type of model makes a lot of sense, particularly for team sports, and is certainly more in line with how we would think about sports from the lens of universal design. And ultimately, it's all about a paradigm shift. So this is also, I think, a great example. You know, Nike has developed a lot of different products. For example, you can look up, there's a tennis shoe called the Fly Ease that's designed universally for people with limited dexterity, where there's no laces, but rather sort of a latch system, so that you can wear the tennis shoes as a young person, and they look just like any other pair of tennis shoes, but you don't have to be limited by decreased hand function. Similarly, they work a lot with, this is a colleague and friend, Sarah Reinitson, who's an amputee triathlete, and they worked with her to develop this sole that you can put on the bottom of running prosthesis so that You can use a prosthesis on the track or in competitive environments, but also if you want to go off-road, you can run, on a trail, for example, or on terrain that wouldn't necessarily be, terrain that's more recreational or more open to simply having fun with friends and family. And ultimately, I really like this Nike slogan, that their goal is to bring innovation and inspiration to every athlete in the world, and if you're a body, you have an athlete. So no one escapes the expectation of being engaged. So ultimately, in our role as sports professionals, I think it's incredibly important that we remember the voice that we have. And, we're really, even by being here tonight, clearly, everyone here, it's probably in a bit of a way preaching to the choir. I think everyone understands the importance of sport and physical activity. And we have to understand that role that we have and the role that we have as advocates and continue to use every opportunity possible. We're really on the front line when individuals interface with disability and impairment, and thinking about how we change the mindset of the individual to one in which people understand that they can be empowered to engage in physical activity and sport. We're often a very trusted source of health and wellness advice, that people really listen. If you're involved in the clinical side or in research or in academia or even leading programs, people listen to you, and I think that our voice really matters. From the standpoint of increased grassroots opportunity, as it relates to that gym down the street, if we don't say something, who's going to? And taking every opportunity possible is extremely important to open up opportunity. And many here, of course, engaged in research to think about what are the outcomes related to physical activity and exercise. And obviously that evidence and that proof of efficacy is extremely powerful for arguing for increased programming into the future. So just want to say that for all of us involved in this sector, we all have a really strong voice and a really important role to play, regardless of what level you're at or in what area of work you're engaged in on a day-to-day basis. So here's some examples, some of the work that we've been able to do. I think that when we look at community barriers and what are those environmental factors that get people involved, this was a very simple study that simply showed that the farther you are from program, the less likely you are to sustain your participation over many weeks to months to years, as well as the fact that people with moderate level of mobility impairment were more likely to continue to come. So if you kind of create that hook and get people to come to a program once, how do you get them coming back? Well, this showed that having sort of a satellite program, like a hub and spoke model, is more effective rather than having just one center in the middle of an urban environment, for example. And also that we need to create more opportunities for people with more severe disability, because that's usually where there's a big gap in opportunity. Additionally, we who work in this sector understand how to keep people participating over the longer term, and wanted to point to some of the work that we've been able to do with the Paralympic Injury and Illness Surveillance Study, which has shown that our athletes are indeed at higher risk for particularly certain types of musculoskeletal injury. And given that we now know that, it's of increasing importance, and we now have the rationale for the development of injury prevention programs that can be efficacious in keeping athletes competing in a healthy way and healthy down the road as well later in life. I wanted to talk a little bit about, just briefly, a model that we've developed at Spalding in Boston, in which we have a unique clinical paradigm for athletes with disabilities who are involved in more sub-elite or elite sport. And this is an important model, and what we do is we bring together a physician as well as a physiotherapist and someone who's really well versed in adaptive sports equipment, all in one visit, because what we find is that our athletes may have access to a sport medicine professional, but if the professional doesn't have expertise or knowledge of the athletes and the way they interface with their equipment, then it's very difficult to treat an injury without looking at the bigger picture of function and equipment. So happy to describe this more if anyone's interested, but we're pretty proud and are now seeing this being replicated in various centers around the U.S. I wanted to briefly touch upon a model that I think is fairly commonly known, that is the WHO ICF, or International Classification of Functioning, Disability, and Health, and just show that what we've talked about today is that it's not just about the health condition. So as an example, you may have someone with a spinal cord injury But if you don't address the environmental and personal factors, things like their equipment, things like school programs for young people, things like transport to practice or transport to a program for people of limited socioeconomic means, and if you don't address personal factors, things like self-efficacy, confidence, and motivation, then you're less able to really impact people's level of activity and participation. So I bring this up because I think when we think about the ICF, or a common model as it relates to disability, we don't always connect it back to sport, but I think we can, and that creates a lot of a really strong argument for the importance of these programs and improving not only quality of life, but also meeting people's rights as a person with a disability. And kind of to close, I wanted to give some ideas of how people can get involved, even if you have limited time, or even if you don't work in this sector day to day. So this is a campaign that's mostly online, called Commit to Inclusion. And if you're involved in social media, there's a hashtag and a handle, Twitter handle that you can use. And this just asks groups around the country and even the world, given that it's social media based, to commit to inclusion in their environment. So if you go to this website, there's several principles with regards to like what you can do to promote inclusion. And this is a really great tool to pass along to, for example, the fitness facility in your community, or potentially a school or a university. And people can sign up to become a part of this Commit to Inclusion campaign. And then you become a part of this international network of people who are really promoting inclusion in physical activity and sport. And you can do it all with a couple clicks. So that's a pretty great tool. So to wrap up, just wanted to recap a couple key points. So we know that that health disparities for individuals with disabilities are real. We know that this population is more likely to experience chronic disease and the impact of sedentary lifestyles. And we know that access to sport and physical activity, it's important for health, but we can't consider it as an extra or a nice thing to do, but rather it has to be an important component of inclusion and disability rights, as has been promoted by our major human rights organizations. When we think about it from the lens of universal design, I think it becomes less intimidating, because when we're creating change that makes the environment more friendly for everyone, not just for people with disabilities. And I think when you pose it in that way, it's less of a barrier to people who may be working on the able-bodied side and be thinking about how to expand programming to work with people with disabilities, but may be a little bit afraid, not knowing how, or not knowing how much it's going to cost, or what barriers they're going to run into. If you argue that it's actually something that makes your program more welcoming and more inclusive for everyone, not just people with disabilities, I think that reduces the level of barrier, particularly attitudinal barrier, that you encounter, and can be really powerful. And ultimately, that we as people working in this space really can be agents for change. And so, use opportunities to voice your understanding for sure, and use opportunities to, even if it's small incremental change at a local level, it all makes a big difference, and it all may open the door for the next Paralympian from your community, or for simply better opportunities for people to live healthy lifestyles. And this is a famous quote that has actually, if you look up who quoted this, you get 5 different answers. So I didn't put a name here, but I like it. And that's, if not us, who, and if not now, when. So now is definitely the time to start impacting change. So thank you. And here's my contact information, both email as well as social media. And just wanted to, this is my 9-month-old daughter, Stella, who, it's hard to leave home to give talks, but for compelling audience and a compelling group here at Left Brow, with all the work that you're doing to advance research, advance paradigms of care and opportunity for athletes. I think she doesn't mind if her mom takes off for a few days, because it's inspiring work. And next time I'll bring her. We've already talked about that. And I really appreciate the opportunity to speak this evening, and I hope we can have some dialogue now about what you're all experiencing, and how we can continue to create change. And I have references if we could distribute the slides after if people are interested. Thank you.